you very much. My case is a type B aortic dissection who's an acute dissection. And I have put on this value of understanding the anatomy using the CT angiogram as one of the important aspects of this case. So he's a 42-year-old obese male who presented with a history of chest pain and abdominal pain about 10 days ago to another hospital. He was a hypertensive. He was diagnosed to be type B dissection, and he was treated with beta blockers, ARB, and sodium nitroprusside. Mind you, the treatment of type B aortic dissection is conservative unless it becomes complicated. And all type B acute dissections have to wait for intervention for at least 2 to 6 weeks unless they are complicated. So he was hemodynamically stable. He had tachycardia and hypertension, had backache, and his chest X-ray showed a left-sided pleural effusion. Echocardiogram was reported to have left ventricular hypertrophy, no regional wall motion abnormality, normal EF, and the bowel ischemia was ruled out with good bowel movements and some of the biochemical tests which we do to rule out bowel ischemia. We go to the next one. CT is not running in my computer, but that you can see this is important to show the CT, and I will probably concentrate on the CT a bit later. I can't show you here, but this is the true lumen, this is the false lumen here. When you come down further, you actually see the true lumen is almost disappearing. You see the celiac which is arising from possibly true lumen, and almost the true lumen is completely gone. So, and this patient was hemodynamically stable, no mesenteric ischemia. I'll go to the next one. So here are the pictures. This is probably the true lumen. Probably somewhere there is the anterior located. And when you see here, this is the true lumen. This is the large, fast lumen, a bit of collection inside the left pleural space. We go further down. You see this is the true lumen. This is the false lumen, true lumen, false lumen. We go further down. This is somewhere just above the celiac artery, true lumen, false lumen. And you'd see the true lumen even becoming small. And you see this is the celiac artery, true lumen almost gone. There's a bit of compromise of the celiac artery at that point. That's the mesenteric artery, which I think comes from the true lumen, and this patient had initially abdominal pain. So probably he did have some bit of abdominal ischemia, which recovered automatically. And now these are very, very important things to understand before we do such cases. We go further down, and you see something here which I will actually explain you later, but I'm just jumping this slide. We go further down. This is somewhere in the infrarenal segment. This is the bifurcation of aorta. This was the CT which I saw when the patient came. 2 days later, he became more breathless and now started having fever. The chest X-ray showed more pleural effusion and his count increased. And a chest physician was called, and they suspected that the patient has some kind of pneumonic effusion, and he's in infection, so he was becoming more and more breathless. And I did a repeat CT, and I thought that there's increased size of aorta, and there was a saccular bulge which was seen on the thoracic aorta and will increase effusion. Although he was treated for an infection, but the patient was becoming worse and was not maintaining saturation. And this is how the aorta looks like. So obviously this patient at type B dissection is now becoming complicated, so he needs treatment, which is within the 2 weeks. And I suspected that he's got a leaked aneurysm, and we wanted to do a endovascular treatment. But I have some concern. And the concern is that the true lumen is extremely small below the renal artery. It is not seen after bifurcation. So how would I access the true lumen? Because if I go from the lower limb, I will probably keep hitting the false lumen. So in such situation, you can do to access the true lumen from the top. You can pass a wire from either the subclavian or the radial or the brachial, the brachial or the radial artery, and snare this wire, because this wire will go into the true lumen. And it's very important you understand that which artery is coming from which lumen for you to be able to understand that which lumen you're actually moving in. And this is the picture. Run. So I can't see in my CT, but is something very obvious in this film. And I will not tell you what. People who understand this will understand that there is good supply of celiac, good supply of mesenteric, maybe a bit slow, but I don't see anything below the renal arteries. Go to the next one. So we decided to seal the entry tear, which is located somewhere there, which I don't think is a very difficult thing to do, but yes, it's important to access the true lumen correctly and put your graft into true lumen by sealing the entry point. So we did that, and this is what the stent graft is, which we are covering the left subclavian here, and this is something all of us have done many times, and I think people who do endovascular stent grafting, this is not a big thing. We'll go to the next one, and you see very obviously now there is much more flow into all the mesenteric abdominal vessels. But is there something obvious now to you? This is my question. So the patient improved completely. He became all right. And about 24 hours to 36 hours later, he gradually started falling his output and shut his kidney completely. No output. So what do you think is going on? So here the anatomy becomes important, and we know, and that's why I concentrated. If you see the right kidney, it's contracted. The left kidney is completely supplied by the false lumen. And the true lumen is only this one which is supplying the true lumen, the right kidney, which is non-functional. So I understand that this patient, by looking at the CT, which teaches me, has now stopped the circulation into the left kidney, and I need to fenestrate. So this is important. So a deduction out of CT that this patient now needs a different treatment, and that is to create a connection between the true lumen and false lumen. And when I go down, next one, so what you see, this is the right renal artery, but that right renal artery actually supplies a kidney which is non-functional, and this is the left renal artery. So what has happened here is that I have gone from the true lumen, and through possibly a re-entry point, I have accessed the left renal artery, which is a bifurcating branch. And initially I thought I should do a fenestration, but that didn't do. So I decided to bridge this using a plain stent. And this is the plain stent which we have put in. And you will see here, the stent is actually bridging across. There is a flap there, true lumen to false lumen. This patient improved completely. His renal function improved. His breathlessness improved. His lung cleared completely. He came for a follow-up 3 to 6 months. He came for a 1-year follow-up. I repeated the CT, and he's completely normal. The aorta is completely remodeled. So the moral of the story is that if you understand the anatomy using the CT, you understand what's going on in this patient, and you create an effective treatment. And this is what the story of the case is. Thank you very much for your attention.